10 rounds. It's been spectacular weather-wise, but the pollen is just making it miserable. It's the only time of year it's just amazing here, and I can't go out because of the horrible pollen. It's this yellow stuff you see all around. Okay, so we'll put together these slides. You can see the CME at the bottom, LOD-BOV. I didn't know this, but Simon Gregory was involved in the discovery of BRCA2 when he was a PhD. And it was 1995, so it's no actual date. I guess Will must have just found this out because they had some commemorative event at London's Institute for Cancer Research. Good job, Simon. You look stretched out in that picture. This doesn't look that much like Simon. Our all-star is Natalie Dupé, who works in 1L, nominated by Vani. And there's a nice example, but I like much better. Not a day goes by in clinic on 1L without Natalie receiving a compliment regarding her sunny disposition and empathy, a sentence that would never be applied to me. Some events coming up. So we're holding an AI event to study post-traumatic epilepsy. Is that right? You're not involved in that?
It's a Duke University thing.
Oh. Friday and Saturday are the end of Ramadan. And this Saturday is both the first day of the AAN conference as well as Earth Day. I thought that was the introduction of medical marijuana to North Carolina, which is not here yet, but should be soon. We just expanded Medicaid in the state. Sports betting and marijuana are the next two things over the next 5 years. So remember, April 25th at the AAN, we're having an event at Legal Seafood Harborside at the AAN. So everyone who's there is welcome. We'll be celebrating the 10th anniversary of the department. We're only 10 years old. There's a documentary with Jamilia Minga, who's in our department, looking at her work into the right hemisphere after brain injury. And it's going to be held May 5th. And just contact Will for more information. 30 years ago at Duke, Mr. Bryan donated $250,000. That was the first of his gifts to Duke. And I didn't realize he was from Greensboro. I think he was involved in the sports network, if I'm not. What was the name of the old ACC sports network? I think that's where his money came from. We started the Bryant Brain Bank, which today has 1,200 brains in it. Len White was part of a team that performed the highest resolution MRI ever obtained on a mouse, made the mouse brain as big as a human brain. And Will just did this so we could look at it. I don't know if it's going to work. Doesn't work. Sorry, Will. But it just reminded me that the cerebellum has 5 connections and we still don't know how it works. This thing has about 100 bazillion. So it just makes you think you might as well give up. So again, this is today's CME, LOD-BOV, and our case presentation is Dr. Tim Collins. Let me get out of that. That's next. Okay, there's Claude. Here is Tim. Screen sharing has stopped. Always like to say when I do this, I talk at the same time, just like my mother used to do when she tried to figure out an ATM machine when they first came out. All right, share screen. And the secret here is you got to share the PowerPoint, not the whole screen. And we're sharing. We're in presentation mode, and we're going to hide floating controls. All right, take it away.
So this is someone I saw earlier this year. This is a 38-year-old, highly educated medical professional who was referred to my clinic with a 6-month history of these episodes where he would have something strange that he couldn't really describe what it smelled like. He sometimes said it smelled caustic. He never used the word burning. He just said it smelled odd. He used the words almost painful. He described them lasting for 30 to 40 seconds. When I talked with him, he had a almost burning pain type sensation in his right nostril only. And he'd been referred to me from ENT with a question of whether or not this was a trigeminal neuropathy or a migraine aura phenomenon. And he actually wondered if it was migraine aura because he'd been trying to read about what this could possibly be. So his exam was entirely normal. And so what's our differential diagnosis on this? So in the migraine world, osmophobia is the word for strong odors disturb the patient or make the headache worse, but it's not a strange odor or something that they can smell that's not really there. Correct. It's typically a strong odor, perfume, cologne. I've seen a few people wear petrochemicals like gasoline fumes or diesel vapor would actually cause a headache for them. And it tends to be really variable when it's osmophobia. It's often really only there just as the headache starts. Migraine aura can have an olfactory hallucination as part of the migraine aura. Migraine aura is a fully reversible neurologic disorder that has both positive and negative phenomenon classically, and it lasts less than an hour. So it's minutes up to an hour long, and it goes away completely. It is described in migraine aura. It's really rare. The few case reports that I can find for migraine with olfactory hallucination describe an unpleasant odor lasting for a minute up to several minutes just prior to the onset of a migraine and only occurring in patients that have migraine, and like other aura can occur without the headache. This guy never had migraines in his life, and he never had headaches with his current symptoms. Olfactory groove meningioma is one of the classic things described as causing olfactory hallucinations. But when you actually look at what's a typical symptom for an olfactory groove meningioma, it's mostly headache, seizures from temporal lobe involvement, and loss of the sense of smell or anosmia. Seizures are also reported to cause typically a burning smell of something burning that's not there. These tend to be a really short duration olfactory hallucination that may be associated with other non-odor type symptoms. And after some discussion with this patient, he actually came to realize while we were talking about it that, yeah, every time this happens, I have this really weird anxiety emotion, but I don't feel particularly anxious. And he's actually checked his pulse during this. He's not tachycardic, he's not sweaty. So it's not like a more generalized anxiety attack. And when I saw him, he was having several of these episodes a week. So of course, we sent him for a diagnostic study, an MRI scan. And unfortunately, this is what we saw. I have a couple images here. This is the contrast enhanced T2 images. And this is the FLAIR images. And you can see that this abnormality actually crosses the corpus callosum to the opposite hemisphere. He was seen fairly expediently by neurosurgery here and had a biopsy, and he was found to have a WHO grade 2 meningioma, meaning diffuse invasive astrocytoma. They did genetics, of course, and he actually had a mutation that was a predictor for a better outcome. There's a whole bunch of social issues that complicated his care, including a spouse who was expecting a child shortly and a previously planned move to another major population center up the East Coast for a job advancement in his medical profession. And so he's right now in the process of starting chemotherapy that's going to carry with him until he moves. But this is a really, seeing someone purely for an olfactory symptom is really unusual. And I thought it was worth presenting this case just because it's so dramatic on the imaging studies. Yeah. He was actually put on levetiracetam by the surgeons at the time of his biopsy, and what I haven't seen him back because I don't need to, and it seems to be in the chart that these episodes have stopped with levetiracetam.
An introduction slide.
Where is it?
It's on its desktop.
Show
Or
me.
if you pull it in the minimize.
Here it is. Okay, just gotta share. Share screen. Here it is. Okay, make it big. Get that out of here. Present. Hide.
Thank you, sir. Great. Good morning. Thank you. It is both my honor and privilege to be welcoming and introducing Dr. Claude Hemphill. As you can see, he's the Kenneth Rainin Chair in Neurocritical Care, the Professor of Neurology and Neurological Surgery at UC San Francisco, and the Chief of Neurology Service and Director of Neurocritical Care at the Zuckerberg San Francisco General Hospital, and is one of the past presidents of the Neurocritical Care Society. Claude got his start at Emory as completing his bachelor's in chemistry, and then was still at Emory for his MD, where he was magna cum laude. He then moved to UC San Francisco, where he never left, to do his internship, neurology residency, his fellowship in neurocritical care, and then 2 years to get a master's in advanced studies in clinical research. So he also has advanced the ranks there as to become the professor of neurology. Now, reading Claude's CV, 54 pages of it, I'm going to distill it a little bit, in that he's had over 20 NIH and other research awards and grants, over 200 peer-reviewed publications, reviews, and books and chapters, and also serves as a reviewer for over 20 journals. His research is focused on secondary injury and neurocritical care patients with both clinical and translational studies that are mostly in ischemic stroke, intracerebral hemorrhage, aneurysmal subarachnoid hemorrhage, traumatic brain injury. He's well known, and he will talk to us about, as he was the developer and the first author of the intracerebral hemorrhage score, which is used in all the stroke centers now. And all of you are aware that you need to do that scoring, since we are a stroke center used in all the US, thanks Claude, as well as the world. So he's also well known as serving as the chair of the AHA writing group for the guidelines of management of ICH, which we've been using since 2015 for many years, until he's also served as one of the authors for the 2022 guidelines, which we're all using today. And he's also been the principal investigator for the San Francisco NET, which is the Neurologic Emergencies Treatment Trials. So just to mention that his current work is in neural monitoring using AI and predictive modeling in collaboration with the Lawrence Livermore Laboratory, UC Berkeley, as well as UCSF. And I saw Duke was in that consortium as well. So his current roles also as a co-chair in Curing Coma campaign, which I think he'll talk to us about an international research effort that's looking at disorders of consciousness. And he is also working with the NIH in developing common data elements regarding coma. So one of the things about Claude is that he is inspiration, not only professionally, but also as a role model. We often talk about burnout. And Claude, well, here's showing also what the year he was president of the society. This is Seattle, where he also plays in a band. So I will see, I'm stalking you, Claude. So I have a gift card to Starbucks for anyone who can name the band that Dr. Hemphill, our grand round speaker, plays in as a lead. Anybody? Okay. So Bubba's Taxi. So if you look it up and you want to go to Corte Madera, you can listen to them play. So also there's his CV also covers a long list of people he's mentored, all his mentees that are leaders now in neurocritical care. But he also served as a mentor to our first and founding president, Tom Black, when Claude was mentoring him in how to use the mic to be one of the singers during that year. So thanks, Claude. Welcome. Okay.
Well, thank you, Cheryl. And that's a great introduction. And I think you left out one really important thing is that, you know, Cheryl is my good friend and we've been friends for, gosh, now, 15 plus years. And to be able to come down here and be with you guys and reconnect with a number of old and new friends is really a treat. And so I'm going to talk about, I'm actually going to expand expand the topic of the talk to talk about prognostication and prediction in neurocritical care. But I want to start with a little bit of a story, because all of us have these stories, these pivotal events in our clinical experience and clinical education, where you say, gosh, something changed. And for me as a thanks a lot, Rich. For me as a neurointensivist and vascular neurologist, it all changed here when the TPA study was published in 1995, and stroke all of a sudden became a treatable disease, and people cared about stroke. And this was awesome because this was really important. And we were able to we changed the paradigm so that patients needed to be treated emergently. And implementing this we didn't really know how to do it at the time because there weren't stroke systems of care. But I remember being a young faculty member in, I think, early 1997 at San Francisco General Hospital, and a patient came in the emergency department, and they were within about an hour and a half of the onset of their stroke symptoms. And people looked around and said, you know, is this a patient that we can treat? And they didn't really know because, you know, we were still working out our protocol. I said, absolutely, let's go. And we whisked the patient over to the CT scanner, and there was probably 20 plus people in the room. And it was very exciting because all of a sudden, something you take for granted now, people cared about treating stroke. And there was emergency medicine physicians and nurses and the ICU folks and myself as the neurology, neurocritical care, and there were CT techs coming around. And at the time, we didn't have the fast helical CTs. And so the scanners would go and you'd see one slice at a time. And I don't know if some of you remember that. And it was this anticipatory thing where you'd watch and you'd see. And so everybody was hovering over this patient, 20 people in the room, and how fantastic. We're bringing treatment to a patient. People care. But you look at the scan. And so we're looking at the scan, and one of the bottom screens comes up. And the next screen comes up. And the next screen comes up slowly. And we see the white. And the entire room went, oh. And then I looked down. I looked down, I'll never forget that. And I looked up and everybody was gone. And the only people that were left in the room was the patient on the CT table, me and the CT tech. And when the entire room had looked at this and seen that it was intracerebral hemorrhage rather than ischemic stroke, they ran away, they left. They were like, oh, nothing to do. And I remember thinking at that moment, wait a minute. This patient didn't come into the hospital to be treated for ischemic stroke. They came to the hospital to be treated. And all of these folks cared, and then they didn't care and they left. This is an opportunity. This is a problem. This is something we need to fix. And I remember at the time also getting calls from my residents, and they would say, seeing a consult in the ICU, it's a traumatic brain injury patient. They have a Glasgow Coma Scale score of 7. Oh, or we've got an aneurysmal subarachnoid hemorrhage patient, Hunt-Hess grade 3, probably has a left middle cerebral artery aneurysm, acute ischemic stroke, NIH stroke, left MCA distribution, NIH stroke scale 22. We've got this guy's got a bleed. It's a big bleed. Remember how we admitted that lady last week? The bleed is not as big as that one, but it's still pretty big. Well, what's their exam? Well, when I pinch them, you know, they're kind of in a coma, and I pinch them and they sort of reach up almost to, I realize, oh my gosh, we don't even know how to communicate about intracerebral hemorrhage. This is a gap. We need to think about clinical grading scales and how we use them in acute neurologic disorders to help us in emergency care and to standardized care. And so that's really the genesis of the ICH score. What's it said? Let's make something that allows us to communicate. That's all we want to do. We'll look at predictors of outcome, and we'll take things that are simple and available at the time of admission, such as a simplified neuro exam of level of consciousness, GCS score, dichotomized hematoma volume, age, location of hemorrhage, some imaging find. Let's add them up and let's get a score that allows us to stratify and communicate about patients. And we know that the higher the ICH score, the more likely, the sicker somebody is, the more likely they are to die, the less likely they are to recover. And so we wrote in the original paper in 2001, and I went back and looked at this because I was like, were we thinking about this at the time? Attempts to precisely prognosticate outcome may lead to inappropriate self-fulfilling prophecies. ICH score and other clinical grading scales are most appropriately used to provide a framework for clinical decision-making and so forth. It's not a precise predictor of outcome. So how was it used? Well, it was used to generate interest in the disease, and there are numerous other external validation studies, and this was awesome because people started to care about intracerebral hemorrhage, and I think it's still been a tough nut to crack, but we're moving forward in this disease. And it was actually used as risk stratifications for clinical trials. You can do that. You can take a scale like this and you can balance and make sure your table 1 is balanced for randomization. And I also found my UCSF neurology residents, they got pocket cards. And they got pocket cards with the ICH score, and they were kind of proud because they said, hey, you know, this was developed here. And so I remember overhearing them saying, here's I'm sorry, your husband has an intracerebral hemorrhage, and Dr. Hemphill developed the ICH score, and the ICH score is 5, and therefore we know they're not going to survive. And I remember overhearing this in the ICU and thinking, what? And I also remember getting a comment that I took as very chilling at the International Stroke Conference, where someone came up and said, thanks for developing this. It's helped me really decide how to deny transfers or outside hospital patients with high ICH scores. And it's always interesting when you think about how your science, sometimes you can't predict how your science is going to be used. And so there's good and bad. But I went back, this is my baseball card of Yogi Berra. Okay, you know, it's not from the Yankees, it's when he was the manager of the Mets. And those of you who don't know, Yogi Berra was a famous baseball player of yesteryear who was famous for his aphorisms, such as it's tough to make predictions, especially about the future. And what we find is people, docs, are just compelled to want to try to predict the future. And, you know, actually prognostication is inherent in what we do. And it's important to understand the definition of prognostication. Okay, it's not saying how things are going to be. It's trying to look in the crystal ball and foretell how they may be. And if you think about it, prognostication is inherent in every interaction that we have in medicine. If you break your arm and you're with your orthopedic surgeon and you say, when am I going to be able to use it again? When am I going to go back and play baseball? You're asking for a prognosis. But in neurocritical care, it takes on a special meaning, and it's desired by patients and families and often will guide treatment decisions. So let's think about how we prognosticate in the current state. Well, what we do is we look at what the patient looks like and we assume what it's going to be in the future. Phenotype. What is the neuro exam at the time we see the patient? Maybe some demographics and medical comorbidities. Phenotype of imaging. Just what is the anatomic imaging of a lesion's location and so forth. Now we can get smart and we can develop some mathematical models like the impact score for traumatic brain injury or the ICH score, but we're prognosticating on the way things look right in front of us. So it's worth asking, what are we trying to do with prognostication? Are we trying to assess distribution of outcomes in a population of patients? Models are really good for that. Are we trying to identify new predictors of outcome as potential targets for intervention? That can be actually very helpful as well as we look at regression analyses of predictors and identifying things that are associated with outcome balance groups in a clinical trial, maybe. But so often, what we're trying to do is predict outcome in a specific patient for the purpose of clinical decision-making. So let's take a look at something like we did a prospective validation study of looking at ICH outcome, and we looked at the at patients in the ICH score and their modified Rankin score, which is that functional outcome scale. And here we are looking at patients' hospital discharge and various time points out to a year. And so what you notice is that the same number of patients had a modified Rankin scale of 3 at hospital discharge and at 12 months. But only 39% of them were the same patients. So if you said, let's look at a population of patients, you'd say, that is an awesome prediction model. That is really good. But at an individual level, it's really not very good at all. So understanding your purpose and how to take that information and utilize it turns out to be really key. So let's move into thinking about prognosticating in individual patients. And this is work 20 years old from general critical care. And what they found is that physicians were overly pessimistic about survival and quality of life of ICU patients, and that ICU nurses tend to suggest treatment withdrawal more frequently than MDs for patients who ultimately survive. Now, my wife is a critical care nurse, and I get it because she would give me a hard time appropriately. So even when I would take care of the kids or the cat, and I would go and say, well, I think Tom may have a fever, and then I'd walk away and say, Pam, maybe he should get some Tylenol. She said, it's just like you do. You go assess the patient, then you walk away, and the nurse is there to take care of them and talk to the family. And that's what happens. Our nurses are really there all the time, and they see that. And so part of it is the milieu of care in which people are exposed. And it's interesting in this study by Rocker that a doctor's estimate of ICU survival was less than 10% was a stronger mortality predictor than disease severity or multi-organ dysfunction or shock. So maybe it means the docs are better at assessing outcome, or maybe it means that there's something else going on. And we know, once again, this is 20-year-old data. It's even more true now. Most of the patients who die in the hospital of neurologic disease or die early after die because we think it's appropriate for them to die. They die because of decisions that we make in conjunction with families and other surrogates that it's appropriate. That's why they die. And I remember when we were putting together the intracerebral hemorrhage guidelines for the American Heart Association in 2010, and the first thing you do whenever you do that is you look at the document that came before. And so we were just looking at the first paragraph, and it said, ICH causes 10 to 15% of first ever strokes. Okay, that's right in the US. And 30-day mortality of 35 to 52%, yeah, it's bad disease, and half of the deaths occur in the first 2 days. Wait a minute. Half of the deaths occur in the first 2 days? I mean, this is in the AHA guidelines. It must be true, right? Why does this happen? Cardiac arrest, brain death? Well, we know, just as we're saying in general for critical care, most patients who die with ICH do so in the setting of withdrawal and medical support. So we must be pretty good at this. Otherwise, we wouldn't be withdrawing medical support, right? Well, let's go back to prognosticating in individual patients, because it's a difficult area to study. If we do a survey and we go ask each of you or maybe other colleagues, well, they're never going to withdraw support on someone who has a chance to make it, but they don't want to instill false hope and so forth. So it's hard to study this directly. You almost have to study people's behavior and activities in an indirect way. And this is a really interesting paper that I highlight because it's 30 years old and it was from traumatic brain injury, and where an experienced neurosurgeon tried to predict outcome on day 1 in 100 consecutive TBI patients, overestimated poor outcomes, underestimated good outcomes, and said you cannot accurately predict outcome on day 1 sufficiently to guide management, at least to limit care. This did not make it into the original Brain Trauma Foundation TBI guidelines in 1995. What did get in there was Glasgow Coma Scale score in pupils about early prognostication. So for some reason, this was decided to not be relevant to those guidelines, but it's in them now. And then Kira Becker, over 20 years ago at University of Washington, well, identified withdrawal of support as the strongest predictor of outcome in ICH. And you might say, duh, of course. But I think the thing she really identified was heterogeneity among physicians in the use of these measures and concern of this self-fulfilling prophecy. And now this has really been seen across all different neurocritical care conditions. My friend Alexi Turgeon, who's in Quebec City, found this in among Canadian trauma centers. And he says it in a much nicer way. The observed significant variation in mortality may be explained by regional variations in physician, family, and community approaches. People are doing whatever they want, and it's laden with bias. Galadriel tells Sam, remember that the outcome prediction model shows many things and not all yet come to pass. Some never come to be unless those that behold the visions turn aside from their path to prevent them. The outcome prediction model is dangerous as a guide of deeds. And if you're Frodo Baggins or Darth Vader or Oedipus Rex, you're very familiar with the concept of the self-fulfilling prophecy, which is a social science construct. It's not a medical construct. But when we go on rounds and your senior professor says, this guy's not going to make it, think you need to go talk to the family, it's time to withdraw support. And they come around a few days later, what happened to that guy? Well, he died. We withdrew. I knew it. These people never do well. Okay. That is called a reign of error. Now, this happened in 1973 with the oil crisis, and it repeated with COVID. Toilet paper panic. If we can have a self-fulfilling prophecy of toilet paper that recurs over time, can there be a self-fulfilling prophecy in medicine? Or, as some of my residents pushed me on back as evidence-based medicine was becoming very prominent as a term in the late 90s, if there's no proven treatment, it doesn't matter what you do. So we said, oh, this is interesting. Let's see if we can study nihilism. We study treatments. Let's see if we can study nihilism. And the general hypothesis is that patients treated in a hospital that have a nihilistic approach towards ICH do worse regardless of other factors. But it's hard to know what nihilism is. So we have this large database in California of all hospital discharges except for military and VA. And it tags whether somebody was made do not resuscitate within the first 24 hours. So we said outcome is related to that, adjusting for patient care and hospital characteristics. And this is important because do not resuscitate orders mean that if they have a cardiac arrest, you do not attempt resuscitation. That's it, period, end of story. But we know that that's not how they're used, that they reflect something about milieu of care. And if a DNR order is in there within the first 24 hours, it means that one of the earliest care decisions was to limit care. Now, I'm not saying whether that's right or wrong. I'm just saying that was one of the earliest decisions in the care of that patient was to limit care. And so we looked at over 8,000 patients, over 230 hospitals. And sure enough, these were sick patients. Our primary outcome was mortality because that's what it's in the database. And about 40% mortality, but about 1 out of 4 patients was made DNR within the first 24 hours. Extremely common intervention and a lot of heterogeneity. And what we found is that adjusting for patient and hospital predictors, the rate at which a hospital used DNR orders in ICH patients early was associated with patient outcome. Not whether that patient was DNR or not, but it was the rate at the hospital was doing it. And we got a problem in San Francisco, and that is ambulance diversion. And so, hospitals get full, ERs get full. And so what that means is if you're heading to hospital A in the ambulance and you get diverted to hospital B that used DNR orders 10% more, your odds of dying just went up by 13%. Okay. What does this mean? It means it's not the DNR order. I've even had people at times say, okay, that's fine. We'll wait to 25 hours. That's not the point. The point is this is a window into milieu of care because it's challenging to look at that. We want to think about discrete interventions, but the critical care environment and the neurocritical care environment is a complex environment. And I recall many years ago, my colleague at UCSF, Wade Smith, would talk about how patients were switched to the DNR channel. And I said, what are you talking about? And he said, well, we went around on rounds and we wrote an order to do not resuscitate. And I noticed that the nurse, well-meaning, went in and changed the channel from CNN, where the stock ticker was going, to the flowers and soft music channel. And I was like, Isn't that interesting? I wrote a DNR order and you decided that they don't need to worry about the stock prices anymore. There are these subtle milieu of care things that really do exist in that environment. So does a doctor's attitude, does a hospital's attitude matter for patient outcome? It is interesting that in this study, the hospitals that use DNR more also did fewer craniotomies, fewer ventriculostomies, and it's cheaper and shorter length of stay. Not providing care for folks really is a cheaper alternative. But we know that mortality may not be the primary measure that we care about. And so we did a prospective study in which we wanted to look at fairly sick ICH patients in milieus that assume aggressive care, if that is what is consistent with the wishes of the patient or the family. So University of Washington and University of Michigan and UCSF, we looked at this to try to understand whether 30-day mortality is less than predicted by the ICH score using those point estimates. And that's the problem in most of these models, is not whether a higher grade is indicating a sicker patient. It's whether you pull out and say, oh, it's 67% or something like that. And then if so, are we just trading death for severe disability? And so this is graph 1, and you can see on the end that the overall mortality predicted for the group was about 50%, but it was actually about 20%. Now, the higher the ICH score, because that's what's on the bottom, the higher the ICH score, the higher the risk of mortality. So from that standpoint, yeah, 4 is worse than a 3, is worse than a 2, is worse than a 1. That's a good scale. From the actual mortality, though, with every ICH score, there was a lower actual mortality in aggressively treated patients. There is a self-fulfilling prophecy for mortality in outcome from ICH without aggressive treatment. So now this, I want you to take just a few seconds and look at this. Now at the bottom is not ICH score. At the bottom is actually modified Rankin scale. It's what happened to the patients. And the blue is the predicted, and the red is the actual. And I consider this kind of a Rorschach test. So I want you to take about 5 seconds to look at this. And then I'm gonna, so some people look at this and they say, wow, a lot of decrease in mortality. And look at this, a modified Rankin score of 3 is independently ambulatory. And for a really bad disease, that often is considered an acceptable or a reasonable outcome. And that's actually been used as an outcome, as a favorable outcome in many ICH studies. So some people look at this and say, look at how many people are 3s and 2s and 1s and 0 back to normal that wouldn't have been. This is great. And some people look at this and say, holy cow, look at all the 5s. These are basically bedbound or maybe vegetative patients. And they say, I can't believe what you're, and both of them are right. It's just data. And if you add it up, there's the exact same number of patients in that favorable outcome that wouldn't have been there, than otherwise wouldn't. And it's always interesting. I actually had somebody, I gave grand rounds and showed this slide at UCSF in another department that will be remain unnamed. And I actually had a community doctor come up to me and argue with me about my own data, that that's not true, that the 5s overwhelmed things. So what's going on here? Well, it means that some people are better off with the intervention of not being nihilistic. And some people are not. And if you consider a Rankin 5 as worse than death, then maybe they're even worse off. So does this mean the treatment of being aggressive is not beneficial? I don't think so, because for some people it clearly is. The task is figuring out in which patients it's beneficial and which it's harmful, and providing the best intervention for them. And if we think of a couple of other studies about prognosticating in individual patients, Anna Finley-Caulfield looked at this a decade ago at Stanford and found, well, they were kind of right about 80% of the time. If your outcome is, are you walking at 6 months? Okay. And when we looked at this in our own subarachnoid hemorrhage population at UCSF, we found about the same thing. We were right about 80% of the time. So is the glass 80% full or is it 20% empty? Is that good enough to make decisions to withdraw support. So that, interesting. And I found this is an interesting study. This is from a medical ICU in Chicago, where they treat very sick patients. About 1 out of 4 of them died. And they did like we often do. They admit them to the ICU with a trial of aggressive therapy because patients are going to declare themselves. And they ask a daily confidential question of all of these providers: do you think the patient's going to die in the hospital or survive the hospital discharge? And yeah, we know about post-ICU syndrome and so forth, but really, mainly, if these patients survived, then they tended to, be ambulatory and do reasonably well. And the hypothesis is that prediction gets better over time. And what you found is if you had at least one day where one provider said they're probably going to die, about half of those patients die. And if you had the day where everybody said they're going to die, your own rounds, medical student, what do you think? Oh, they're going to die. Fellow, they're going to die. Resident, they're going to die. Attending, they're going to die. Nurse, yeah, they're going to die. Well, we ought to go talk to the family, so forth. 84% of those folks died. 16% of them didn't. And what they found is that prediction didn't get better over time. It got worse the longer the patient was in the ICU. And that should not be surprising, actually, because the people that get better quickly leave the ICU. They're not there for prediction anymore. The people that die quickly leave the ICU and are not there anymore. It's only the people that we don't really know how it's going to sort out that remain. So once again, this is the milieu in which we find ourselves. So why can't we get this right? We just need more mathematical models. Let's cut the ICH score at 26 cc's and a GCS of 11, right? Maybe we need more data like multimodality monitoring or imaging of consciousness networks. Or what about bias? Has anybody ever seen this in the chart? Has anybody ever written this in the chart? We discussed the options with the family and they decided they did not want surgery or ICU care. And whenever I read that, I wonder how much was discussed and how much was told. So this idea of cognitive bias is sort of interesting. I asked Bob Wachter. Bob Wachter is the chair of medicine at UCSF, and he's written a bunch on medical errors. And I asked him, I said, Bob, if somebody says they're gonna die and they actually have a good chance of favorable recovery and a decision is made to withdraw support, is that a medical error? He said, nah, I'm really talking about cutting people's legs off without checklists and so forth. And I said, I find that hard to believe. So even in the medical error community, inaccurate prognostication tends to be considered the art of medicine. This is a tough thing. It's hard to know. So there's a lot of cognitive biases. And Benjamin Rohat and Jan Clausen wrote this as potential issues of all of these different biases in decision-making in neuroprognostication. And take a look at this. It's pretty interesting. And these make sense, anchoring and framing. But I want to bring a specific attention to loss aversion, because loss aversion is often seen as saying, I missed a chance for a good thing to happen. But what I've seen a lot in neurocritical care as well is loss aversion is if you decide that somebody is not going to make it and we make a decision to withdraw support, we actually never know our error. But if they don't make it, if they do make it, but they're devastated in terms of their neurologic outcome, and there was controversy at the time of the decision making on that error is there for everybody to see. And that is actually a type of loss aversion. There's a lot of ways to get this wrong. And oftentimes we're talking about prognosticating futility. So this is challenging. But, some of this gets down to saving money, right? That's the elephant in the room. Looks like in 2011, they're predicting that Medicare is going to be insolvent by next year. I don't think that's going to happen, but this is a big, big problem. So they looked at this in a Canadian study of intracranial hemorrhage, and I thought it was pretty interesting because what you find is it's much more expensive to take care of survivors than it is for those who died. And where are the costs? The costs are in ICU and nursing. So that actually mirrors probably the closest thing to a cost utility analysis of end-of-life care in critical care that I saw from John Luce and Gordon Rubenfeld from 20 years ago. The only real way to save money is you don't need a 37-bed neuro ICU. You need an 18-bed neuro ICU. So go close half of it and fire the nurses and the respiratory therapists and the doctors. Like fundamental social change. Otherwise, those beds are going to fill up. It's cost shifting rather than cost savings. And finally, thinking about communicating prognosis. Patients and their surrogates don't believe what we say, right? Well, they do sometimes. But is that because they're wrong? Is that because they're wrong? Or because they understand uncertainty perhaps better than we do sometimes? Interesting study looking at what surrogates hear. And if you say he's got a 90% chance of surviving, they hear 85 to 90%. They say he has a 50% chance of surviving, they hear 50 to 65. He has a 5% chance of surviving, they hear 5 to 40%. He will definitely not survive, they hear 0 to 50%. This is also where we are. And I think it's important to understand this idea of patient-centered outcomes and prognosis for what? Different outcomes may be considered acceptable for different patient surrogates and physicians, and this idea of the disability paradox. I never want to be that way, but now that I am, I'm glad I'm alive. So let's finish up by going back to this phenotype versus endotype. Let's go back to my residency in 1993, and this acute stroke patient comes in, and they've got a global aphasia and a right hemiparesis, and saying, what's their prognosis? Well, I don't have an acute ischemic stroke treatment. I've just got a non-contrast head CT scan that's negative. What's their prognosis, and how do we make those decisions? We base it on phenotype, right? Well, what do we do now? Well, we get a stroke CT, and we define the endotype for a middle cerebral artery occlusion with a cerebral blood flow decrease, and we can further define it with a mismatch so that there's a salvageable tissue because the cerebral blood volume is preserved, and we take them to angio and we do an embolectomy, and we're doing precision medicine patient management based on endotype, not phenotype. So we've actually done this in ischemic stroke to a significant degree. Okay, so this is possible. It's endotype-based management. So in the context of disorders of consciousness and coma, we're starting to see some interesting concepts. And this has been around now for over 10 years, in which a group looked at post-acute patients and looked at functional MRI and found that, and these were across different diseases, including stroke and traumatic brain injury and so forth. 9% of them had awareness. And Jan Clausen looked at this and identified cognitive motor dissociation, basically patients on their phenotype who aren't responsive, but on their endotype, on the advanced machine learning EEG, are responsive. And those patients, 44% of them had favorable recovery compared to 14% without. Starting to get at this idea of looking at networks, reticular activating system, functional networks, and TBI. And I wonder if this part of this is the biological mechanisms of our prognostic uncertainty. So I want to just tell you very briefly before we conclude about the Curing Coma campaign. Cheryl mentioned this. Journal Science identified that the #1 scientific problem is what's the universe made of? So unless you're working on that, we invite you to work on #2, which is biological basis of consciousness. And we've set out a framework for endotyping, biomarkers and proof of concept clinical trials, a scientific roadmap, had 2 NIH symposia, and gap analyses. World Coma Day just concluded, and we're putting together the numbers. And I invite you to sign up to be part of this, and particularly emphasize stories of hope, which we tell the stories of our patients that get back to our providers in the ICU. And this is really key. So I'm going to conclude with my neurocritical care predictions, which are bedside neurocritical dashboards with AI will be used to proactively assess and treat patient state. Tele-neurocritical care expert consultation and management across states and countries, functional neuroimaging and routine use in neurocritical care, brain pacemakers for minimally conscious state and chronic coma, and neurogenesis restorative treatment. Problem is, people may be wrong with their predictions. And here are some famous predictions that turned out to be wrong. Rail travel will not be possible because patients would be unable to breathe and would die of asphyxia. The telephone has too many shortcomings to be seriously considered as a means of communication. Western Union found it of no inherent value. X-rays will prove to be a hoax, according to Lord Kelvin. Horse is here to stay. Automobile's a fad. The president of Michigan Savings Bank is advising Henry Ford's lawyer not to invest in his motor company. Einstein thought there's not a chance that the nuclear energy will be obtainable. Decca Records found they don't like the Beatles' sound and guitar music is on the way out. And Ken Olson said in a keynote address in 1977 as chairman and founder of Digital Equipment Corporation that there's no reason for any individual to have a computer in their home. Most of these resulted from underestimating technological potential and assuming that the current status quo is good enough. So we conclude by changing the title to ethical decision-making in neurological catastrophes, because that's really what we're talking about. And what I want to say is prognostication is important and appropriate in the care of neurocritically ill patients. And we actually are pretty good in broad terms, but uncertainty is inherent and the self-fulfilling prophecy is real. And family communication is challenging and often discordant. We have to be humble and not impatient. Focusing on patient surrogate preferences is key. And this sometimes is hard for physicians, especially in deciding procedures. We need to be humble regarding our currently limited assessment of the underlying biology regarding capacity for recovery. Phenotype is not endotype. But we still have to make decisions now with our patients and families while being part of making things better for the future. But I will leave you with nihilism is not an effective treatment strategy. So thanks a lot. I'm happy to take a few questions now or later.
So unfortunately, there's a group behind us, which I've reserved this till 10. So Claude, would you mind taking the questions outside?
I'll be right there.
So I just want to make a comment because we have a couple minutes. You know, you sound just like a preacher. Has anyone thought that's my preacher? You're a really gifted speaker.
Oh, that's very kind.
But let me ask you one question that we talk about all the time. You're running the ICU. Someone in an outside hospital wants you to send you someone with a giant bleed. You think it's going to do poorly. There's maybe a neurosurgical case that wants the bed. How do you handle that?
Well, that remains a challenging and individualized decision. What I would say is that one of the things that we try to do is, and it doesn't always happen this way, is we try to have this discussed ahead of time in terms of overall concepts and philosophy for the teams. And so one thing we've gotten rid of is the idea that they aren't going to come unless they get a procedure. And I think that's very, very, very common. But, you know, certainly we have to make triage decisions and, you know, there are limited resources. And so understanding the capability of what's at the outside hospital and doing, you know, making the best you can. So I don't necessarily answer your question precisely. They're probably not going to survive if we leave them there. Yeah.
All right. So questions outside again. Thank you so much. That was just wonderful. That was just wonderful. You're a really talented speaker.
Happy to see.